Okay, everybody, welcome back to Your Crisis Coach with Scott H. Silverman and myself, Fred Carroll. Today we got Dr. Arun Gupta on, and he is going to tell us all about his life and stuff. But first, how are you, Mr. Scott Silverman?
I am great, Fred. I'm hearing the gardener next door now. I may have to close my door. Let me know if that's too loud. I'm doing well, had a nice Mother's Day. Hope you celebrated to the best of your ability to have a Mother's Day, you too, Aaron. And my kids are doing okay. My daughter just had a major flood in her office, so they said it was gray water. And since it's California, now they have to tear the walls apart, put a hole in the roof, bring a crane in, and bring in dog sniffers that make sure there's no mold growing. It's just so crazy. So she'll be out of pocket for about a week and a half. And she just rents space. So otherwise doing good. I want to lose some weight this year. That was my goal. And so far I'm way behind it. Otherwise, great. How about you, Fred? How are you doing?
I'm pretty good. I had a book signing on Saturday.
How'd that go?
I'm not as well as I wanted to, but I'm just not in the market. I'm not a great marketer with face-to-face, at least. On these podcasts, on video, I'm fine, but face-to-face, I'm not good at talking about me in a public forum. And you have to have a little bit of narcissism to be an author and to sell your book, because all you talk about is you, when they ask. So I have to learn to be better at that. But overall, I sold like 10 books. It's 10 more than I sold the day before. I'm happy. And I got to meet a lot of great authors, and it was nice out. That's the most important thing.
Well, that's good. From what I know about our guest, he's not shy, and he will help, I think promote not only himself and his books, but he's also been in the business of saving lives. So, Aaron, it's really great to have you here today. So let's swing it over to you, and let's pretend that you're talking to people that don't know you, because you will be. They may not know you. Some may. You have quite a reputation, but, I'm on the West Coast, and things that happen here, people hear about. So it's really great to have you here. It took a few weeks. Thanks for your patience with moving some things around. We had a VIP guest that was very picky about the dates, so we got you in the month of May, which you wanted to do.
And don't forget, Scott, my colonoscopy.
Oh, well, yeah.
We had to have that.
He instead of calling in sick to work, he told his boss he's having a colonoscopy. So yes. That was a good one, Fred. I've heard a lot of them, but that was one of the better ones. All right, Aaron, it's all yours. You got the floor. Tell us who you are. Again, pretend nobody knows anything about you. You have 30 seconds. Go.
Scott and Fred, thanks for having me here. I've been a primary care physician in private practice for nearly 40 years. And I have been, in addition to working in my office, taking care of my patients, seeing my patients in the hospital when they get sick, and at the nursing home. I've done that for nearly 4 decades until recently I quit going to the hospital and the nursing home. But before I quit that, I had other wide experience. I was a part-time emergency room physician. For 11 years, I was the local jail physician and ran 2 jails. And I was also deputy medical examiner for 8 years. So I had seen human suffering from a very wide range that most physicians don't get that experience. In 2006, the jail found a national company here in Monroe to take care of the jail business. And so I had some free time. By that time, I was feeling a pinch why young people are getting addicted and dying from drugs. So I joined a very prestigious organization called American Society of Addiction Medicine. And I'm very thankful for them to have taught me what they taught. Around the same time, I was invited to become a Rotary member. 5 years ago, while I was writing my book, I ran into John Hugo, the Secretary General of Rotary, in a meeting in Ann Arbor, Michigan, and I was trying to convince him that Rotary should take up the opioid epidemic as a project. I think the Rotary International Board probably was not ready for the change, and as I understand, they may not be there for the change either at this point. In 2017, CDC had said 2 things. One, the highest number of people had died that year was 70,000 before the numbers were gradually creeping up. And collectively, 700,000 people had died from drug overdose in the previous 18 years. I was having dinner with a friend, elderly friend from the hospital, and she said, Doc, when is all this going to end? And I searched my soul, my brain, and I said, Glenda, I don't have a good answer. She said, what do you mean? I said, when everybody dies. And she gave me a dirty look. She unfortunately passed away a couple of years ago at the age of 86. But that made me thinking and researching. I'm in a rural community, non-academic setting. I sat in my office and home long hours, 3, 4 hours every day after work, before work, and between work, and finally came up with a book, The Preventable Epidemic. It's my research. It has 140 citations. As the book came out, and also around the same time, I had joined a Rotary Action Group, Addiction Prevention, which is a subchapter of Rotary. And I told Larry, the chairman, that I have no interest in addiction prevention. My goal is to help promote treatment. 4 years ago, roughly 3.5, 4 years ago, they made a SMART chapter, SMART, School Education, Medication Disposal, Awareness, Recovery, and Treatment. And I promote medication-assisted treatment promotion on the North American platform under the RAG app. As soon as a book came out 3 years ago, I was invited to speak at Houston Rotary International meeting 3 years ago. And again, we have an opportunity to present at the Calgary Rotary International meeting. I would be speaking on June 21st on a Saturday at 3:30 p.m. And Larry had asked me to connect with you, and thanks for inviting me here. I'll be happy to answer further questions, and hopefully that's enough for my introduction for now.
Well, that's quite a resume. So let me ask you, because I want to take a couple of minutes about Rotary, because I know both of you and I are on the board of this RAG group. So you've been honored. How did I hear you say that this was an idea that you brought forward originally? Is that correct?
I brought it to Rotary International's attention 5 years ago. We had a lot of meetings with John Hugo, his staff, even one of the editors. So it was my idea that I pushed 5 years ago. And I was very hopeful, but at that point, they did not publish my article. Last year, a year and a half ago, they did do a story in the cover page story in the Rotary International magazine. And it's about 10-page story and has a full-page picture of me in there. Yes.
And how much of your time have you been able to spend with Rotary, and how often do you speak to clubs, and the key message that you bring there? What does that look like?
Well, overall, on different platforms, I've done over 1,000 presentations, and most of them have been in the last 4 or 5 years as I was gearing up for my book. But I've spoken in different clubs in Canada and in USA. It happened a lot during COVID because it was easy to do it on Zoom. And now a lot of places it is live meetings. People are not doing Zoom meetings. So, and since the Rotary International has not endorsed this idea as yet, so our district or district governors are not asking me to go and speak on this topic, which is a drawback, but that's the intention, to raise awareness in Calgary so that we could have people understand what the magnitude of the problem is and what needs to be done.
So what is the magnitude?
Go ahead, Fred.
So the magnitude, according to American Society of Addiction Medicine, there are 49 million people in America, which is about 12% of the US population, that is at risk of polysubstance abuse. So we're not talking just smoking or just marijuana or having a couple of beers a day. We're talking about 4, 5, 6, 8 different products being abused in a given day. That's polysubstance abuse. We cannot quantify of that how many are just narcotics alone. Okay, so we have 100 million people that have chronic pain. At some point in time, 10, 15 years ago, a lot of these people were on narcotics. And as the regulations came into effect, these people could not get the prescription narcotics because 1,000 doctors have been put behind bars and they lost their license taking care of these difficult patients. So these patients were forced to go to the street and the street drugs became a lot more serious than heroin and cocaine. You know the name fentanyl, and Scott knows a lot more living on the San Diego border. And you have heard his discussions with the media people. So now, virtually in the last 4 or 5 years, the 100% of the deaths are from the street drugs. It's not doctors, it's not prescription medications. And so the regulations that have been put in place since 2010 or so are still in place. So the doctors are scared, and that is the magnitude of the problem. We have lost over 1.5 million people in the last 25 years. And the last 4 or 5 years, the death rates have been consistently over 100,000 during COVID, with a little bit dip last year, and we're still not sure, is it the critical mass of people abusing us down, or pushing too much Narcan, or people are more getting smarter about the use of fentanyl. And 94% people with substance abuse do not have access to care at all. There are not doctors enough either trained or wanting to take on this challenge. So we have less than 7,000 providers who actively provide care to patients with addiction out of 1.8 million doctors, nurses, and NPAs in America. When I wrote the book, my estimate was it was 18,000. But 2 years ago, I had attended a meeting with SAMHSA, and they gave me a number that year was 6,885 providers in total to take care of 2.4 million people. And CDC had said consistently, the people waitlisted for treatment have a very high mortality. My patients have 85% success rate. They're working people like you and me. They get better, they back with the families, they go to church, they get better education, they excel at work, get promotions, go on vacations, buy new cars, new houses, and come and show me, Doc, I got money in my wallet, I never had it. And they're very thankful. And they're the nicest people I have ever met in my life. And I have hundreds and hundreds of them. And that was the reason I wrote the book. I wanted to show that these people who nobody cared, and now they are doing so well. We keep on showing the same doom and gloom, but we do not show the success.
You know, I heard you said something. And I'm wondering something when you said about because there was a time, I don't know the exact year, you probably do, when all of a sudden the DEA and the DOJ was putting pressure, maybe even the AMA, on doctors, and then the pharmacies about script writing. I was just putting something again. I wonder if that was a trigger for the cartels to when all that noise about, especially with pain, where there were, pain doctors that were just having people line up and come in, and they were just filling scripts, hand over fist. I know in California, there was a lot of doctors that got in trouble, but it took years to prosecute them to slow it down. But when I heard you say it the way you said it, I'm just wondering if I was sitting out there as the cartel who was having difficulty, speeding up the manufacturing and cultivating and distribution of cocaine, and I wanted to get a drug into the United States, what better than fentanyl? An opioid that was a synthetic that could be created quickly. And I'm wondering if the way we managed our problem was a incentive for another country, and then
Sure.
of course precursors in China, so two major arms can make tons of money. And now that the people, as you said, people are getting smarter about fentanyl. So is the cartel. They're changing the way they make it because they found that they were killing a lot of their consumers. And but we're still seeing overdoses seem to be diminishing. And that's assuming that the feds don't take Narcan off the market, which they could, naloxone, but also people have gotten smarter. But I don't think the volume of people being addicted or the people who suffer from substance use disorders has gone down, but maybe the overdoses have gone down short term. But at the end of the day, to your point, with that many different providers and that many people that are needed, but this disease of denial, the average person doesn't raise their hand and say, "Hey, Dr. Gupta, I think I have an addiction problem." It's usually, I'm sure, a family member that calls you and tries to get their loved one into care, unless they're coming in on a gurney handcuffed by law enforcement, or they're unconscious because of something that took place with some of their activity. So
So
what do you?
let me answer the first question first. The prescription medicine versus street medicine. So in 2009, the FDA and the DEA together told Purdue Pharmaceutical that the OxyContin is abused. The death rates nearly reached 30,000 that year, that you got to do something with, and they forced them to make it abuse potential. So they made a formulation where it could not be crushed. And there was a dispute between FDA and DEA, and they were saying that there is more OxyContin per pill. But as the formulation was changed, people were less interested in buying the OxyContin in 2009 and 10. And Opana was told the same year to do the same thing. So the heroin sales went double, and the death rate started to climb from 30,000 to 40,000 to 50,000 to 70,000 by 2017. So that was the first wave when this heroin overtook and the prescription medicine started to go down 50%. Then 2014, we started seeing fentanyl in the urine drug test in young people. And fentanyl is a very good drug. It's safe. It's Schedule 2. My surgeon friends use this in the hospital for pre-op surgery and during surgery, hang an IV drip and then shut it off and the effect is gone. I used to, and other doctors on the outside would write fentanyl patch for 72 hour of pain control. It came in 25, 50, 75, or 100 micrograms, and it was safe. We never had any problems. So we all panicked. We didn't know where this fentanyl was coming from. It took the federal government 3 to 4 years to figure out that it's flying directly from China to the labs in America. So the Trump administration, forced the hands on China and said, you cannot mail it to America directly. Guess what? The border opened and it started to freely flow via Mexico. So now fentanyl is taken over, as you know. 9 out of 10 cars crossing the San Diego border do not check for drugs. So the drug dealers know that too. So it's a very easy way to bring these in without having to charter boats and planes.
So it was China, if I heard you right, that was told by DOJ, I assume, and DEA, you can't sell it. You can't sell the precursors to us.
The American labs.
So they went to the cartels, or the cartels
went to them, yeah.
And they became the consumer of the precursors.
Yeah.
Interesting. So the cartels, well, the cartels already had the transportation highway because of cocaine,
yeah.
And heroin. So it was easy for them to just put another drug on the truck, so to speak,
sure.
or another drug on the boat.
Cheaper drug with more money and more lethality.
Right, and it's a lot less weight than a pound of marijuana, and can serve a lot more people. So that's interesting. So
the other thing about the fentanyl is 2 milligrams that sit on the tip of the pen is a lethal dose. This much is a lethal dose.
Right.
Okay. So it's when they mix in a big container, have crushed Xanax or Klonopin, and they compress the pills after mixing fentanyl. We do not know each pill has 0.5 milligram or 4 milligram or 5 milligram. There's no scientific way, to do it, and that's why some people get a higher dose, some people get a lower dose.
Our DA here in San Diego, based on data, and of course the medical examiner as well with the autopsies, has claimed that almost 90% of the illicit drugs that are seized, caught, or diagnosed in individuals who have expired or caught on people have some level of fentanyl in them. So fentanyl, and that's the accidental overdose, is that mix of fentanyl with anything else like Xanax or cocaine or crack or methamphetamine. We see a lot of that. And of course, the cartels already had, again, the distribution centers for methamphetamine. So it was easy for them to piggyback bringing fentanyl in. They already had the highways. Just like when marijuana became legal in California, the the big distributors went to the tobacco industry and said, how did you get started on the, distribution highway? How can we mirror what you've done? And I'm sure they paid a couple of consultants a lot of money to show them how to do it, to make it easy once it became legal.
So in one of my earlier presentations, which I'm not going to use it here, I had a slide of when I teach like the students and stuff, that when we're talking about smoking, say 1950, 50% of the US population used to smoke. And 100 years ago, there was nobody dying from lung cancer. And now it's 100,000 plus people die every year from lung cancer. So that all happened from the corporate greed because they figured out how much of nicotine in each cigarette that is addictive and abusive that people want to use again and again. And I think the marijuana story is 10 times that corporate greed. It is a very strong drug today as compared to 20 years ago. It used to be 4% potent. Now it's 25-30% potent. It's a totally different drug. I one time stopped at we have marijuana stores, about 25 of them within 2-mile radius because it became legal in Michigan.
Yeah. And remember,
so I'm asking the guy at the gate, about marijuana. He says it's very strong. He says, even I tried to smoke a whole joint last night, and I think I overdid it. So even for a person doing regularly, one joint was too much. And so when we keep giving this to the younger people, their brains are getting permanently fried. I have patients who have kids 13, 14-year-olds smoking marijuana, and I asked them, I said, who locked them?
Wait a second. Did you just say that you smoked a joint last night and you couldn't finish it? Is that what you said?
The guy who smoked the joint, who works at the place, he said he could not finish the joint. It's too strong.
I thought you meant yourself, because you seem
No.
I
don't use.
Being a doctor, I would see you don't only want to introduce edibles so you wouldn't have to deal with carcinogens.
No. I'm talking about the guy at the store.
Well, my hearing's not that great. I don't have my hearing aids in, so I'm glad I got clarified, because I don't want anybody to misinterpret the fact that our special addiction specialist only smokes a half a joint every night so he can sleep better.
Yeah. Oh, thanks.
So what did you see? We had talked about how you came into my area, and I assume when you come into different states and stuff, you do look around. You don't stop working, in a sense. So I had called the Rotary Club in New Haven and West Haven, and I wanted to go to the meetings. And I think there was some confusing and mixed messages. Meeting was on Tuesday or it was on Wednesday, and so I just didn't attend the meeting, but I would attempt again when I go next time there. And Phil, I'll be happy to catch up with you. I'll get your phone number from Scott, and I'll contact you when I'm in the area. Yeah, that'd be great. What did you notice about Connecticut, or did you see the addiction? Did you see it as rampant as everywhere else?
I usually talk to people if I'm in a cab or I'm going some places. And there are pockets that are heavy with addiction in the Yale area and the surrounding areas. And some areas, they say it's not as prevalent. So it's more rural areas, less fortunate places where people don't have enough education, not have enough resources. Same thing in my rural town. It's really bad. I'm the only provider. So it really, there's a lot of very well-off, educated people, but nobody's immune from this addiction and this drug problems. The incidence rate is the same. I would say the people with higher socioeconomic status have more resources to use and abuse and then cover up. But the poor people have to kind of, some rich person's kid gets in trouble, or spouse or whatever, they go to Betty Ford Foundation in California, spend $100,000 and feel better and come back. But they need follow-up doctors like me to continue the treatment, and otherwise they're going to relapse down the road.
Well, what is it that you're doing that's working with the rates that you're getting?
So I'm getting 85% success rate. FDA-approved drug called Suboxone or buprenorphine about 25 years ago, was available starting in 2002. And I started learning this stuff in 2006 on my own. They do not teach this in American medical schools or any medical school in the world. So it's just hit and try. A few doctors here and there feel the need to do it, and then they try to protect their turfs so others cannot take the business. And that's what I feel. Um, Buprenorphine comes from the opium plant, and it is a has a strong binding to the mu opioid receptors in the brain. As the narcotics leave the brain, this drug goes and sits in the brain, and it does not let the opioids do anything. So my stable patients, if they have to go for surgery, emergency procedure, they have to withdraw from my medicine for 2 to 3 days. Then they can get IV pain medications or pain pills for a few days, and then they go back to the um, my medication, buprenorphine or Suboxone. The other concept is if you're loaded with narcotics and you take my medicine, you're going to get violently sick. The problem occurred, we were started this discussion a few minutes ago about the pharmacies and DA regulating prescription medication. So 10 years ago, Suboxone was being abused and traded on the street. So a lot of pharmacies got in trouble. In Midwest, at least I know half the pharmacies did not carry Suboxone. I still see a lot of pharmacies not carrying it at all, and some carrying it to the least amount. Um, and That creates a problem with the access. The regulations have been created. If I write 30-day prescription and the patient is going out of town, the pharmacy is not going to fill the prescription a day early. So they have to go through withdrawal uh, to otherwise they have no choice. And the regulations do not realize people will relapse because the withdrawal of narcotics and Suboxone for that matter is equally bad. People feel much worse. So they need to continue the medications, just like insulin. If the pharmacist says, I'm only going to give you 30 days and tomorrow is Sunday, we're closed and you can have your insulin, that's not right. It's a chronic, very lethal relapsing condition that requires long-term treatment like any other chronic medical condition. And people have a right to get the medicine without any problem. The doctor should be able to prescribe medication without the fear of intimidation by DEA, FBI, regulations, insurance companies. If I have to tell you how difficult it was in the first 10, 15 years of me to deal with this issue, it was a nightmare. I had to be really stupid and crazy to be doing what I was doing. But I stood there for the sake of my patients. It was a really, really very difficult situation, and that's why most physicians do not want to learn addiction medicine.
So, what do you think is going to happen? I just read that CVS and Walgreens, because of the opioid settlements they've had to go through, are going to close between them 2,000 pharmacies. I mean, that's a lot of pharmacies. I don't know how many pharmacies we have in the country, but two big organizations that big brands out here anyway. What's going to happen to that person who may have to wait a day? They may have to wait a week, and if they're not real good at medication management, or the doctor can only prescribe X and they have to wait till Y opens the door for the next renewal, because there's still a lot of people, I would assume, that have pain out there, and the Oxycontin that studies show long term didn't really deal with the pain, but they had to substitute with something. And I know a lot of people went to heroin initially because they were unfamiliar with fentanyl. So what's going to happen, do you think?
Well, so let's go to the nicotine settlement money that came. Nobody knows where that money came and where it went. And it didn't do anything to patients who got sick, died, or anything. They just promoted some stuff that there is no results. So same thing, like my town got $800,000 and we had 24 applicants who applied for grants. I have a 501c3 in addition to doing my regular work to do my other stuff on the side. And everybody got some money and they did not give me a dime. So this was the third or the fourth time I got rejected. And so they do not appreciate or they do not want to fix the problem. But the problem is created worse by the government. Government is responsible for this mess. in the beginning, with how they did the regulations, did not control the oxy content like they control the Suboxone. The company that makes Suboxone got sued by the federal government for $2 billion, while Purdue got sued for $4 billion for creating the problem, and they were trying to treat. So think of this. This is 1995. OxyContin sales and overdose deaths is going up. 2002, Suboxone comes in with the criminal activity behind it. In 2005, as the death rates are going up, the government says we're going to monitor the sale and distribution of Suboxone as it impacts the communities. That was the second step towards the criminalization of the treatment arm. And then they sued the company. That's the third step towards the criminalization of the treatment arm.
Well, it sounds like, when you frame it like that, Purdue obviously had a much better lobbying team and took care of the, government. I remember that town that, somebody was writing, a couple million scripts a year, and there was a town of like 8,000. Everybody was going, and the DEA, I've always been baffled by this. When somebody manufactures something like that, buprenorphine or OxyContin, there's a number assigned to that batch that the DEA controls. Then it gets shipped to the pharmacy, who then has a control number, and they have a license like a doctor, and that is connected to the tail of the butt of the doctor or the pharmacy or the hospital. And it's fascinating that they knew this was going on. It was a big expose on 60 Minutes a long time ago. And basically the DEA person, I think their face was covered and their voice was disguised, said that they were told by the DOJ to leave it alone and not persecute or prosecute the distributors, because I guess the lobbyists had made the deals with the decision makers. And, you heard the scandal with all the doctors.
Purdue had a hand in the cookie jar at all places. They were a board member of the AMA. They were in bed with the federal government, and they were giving money. They were donating to all the big organizations worldwide. Okay, so and they could manipulate. I wrote about it. I have a chapter on AMA and a chapter on laws only apply to those who cannot fight it. So now a small guy like me, we have to suffer. Purdue manipulated the system to the end, and still they don't have any criminal charges.
Yeah. Fred, what's on your mind? You've been quiet today, as you like to say to me.
I like to listen, and I'm very, it's nice to hear somebody that's educated in it. I get to hear that from Scott all the time, but you get one voice all the time isn't always the same. So to hear it from someone else is nice.
I don't know how to take that, Fred, but
I know. Well, that's why I worded it such, so you can't get mad or
there's
sad.
There's an underlying dig there, and I think the doctor picked up on it. He just texted me.
He understood.
Give me a virtual hug. Go ahead.
He understood it, but what I worry about with these, are we better off today? Are we better? Is anything changing? Do you see a future where it is solved, or
I could answer that question. So in the last 25 years, the regulation created to not have as much distribution of narcotics, and doctors who were writing unnecessarily too much narcotics was stopped. But what happened is the access to care. Now, after 23 years, the federal government realized the regulation that put in with Data 2000 were too restrictive. Do a course, pass an exam, get an XDEA number for doctors to do that. So 3 years ago, they passed a law called MATE Act, Medication Assisted Treatment Expansion Act, which went into effect 2 years ago. That says now any doctor without any training can prescribe buprenorphine. It's like I've never done surgery in my life, and I'm sure you guys do not want me to open your belly and take your gallbladder or appendix out, or do somebody's heart surgery or brain surgery or joint surgery. So doctors need more training, not no training. So even though they try to expand access to care but there is no new doctors in the last 2 years since this MATE Act went into effect, have started doing more, treating more patients for addiction. So the more people are not getting treated, death rates are still very high. And that's what my goal is. First goal is to reduce the overdose deaths worldwide. And that can only be done by promoting medication-assisted treatment or medications for opioid use disorder. And that necessarily does not mean Narcan alone. Narcan only prevents overdose deaths. It cannot keep people in remission once they wake up. And so we can't be using Narcan again and again. And so these people need to get in treatment from providers like me and get the medicine on a monthly basis for daily use. There is a monthly shot available. Uh, it's but expensive as compared to $100 of medicine a month. That shot is about $1,800 a month. So the insurance companies do not like it to spend
Is
that.
that Vivitrol you're referring to? Vivitrol?
It's called Sublocade.
Sublocade. Okay.
Yeah. Vivitrol is a non-narcotic. It's still $1,500. It blocks the opioid and the alcohol pathways. But the success rate in general population is very poor. The legal system has used Vivitrol in the last decade in some states where there were drug courts and stuff because it didn't require a doctor. The judge could order the Vivitrol shot. You're in jail. You get the first shot in the jail. The company provided the second shot. They gave him on the day of discharge because the Medicaid would come into effect. And then patient is discharged, hoping patient would follow up, but then they disappeared. So these people had very high relapse rate and did not comply with the laws, but they got out of the system because the treatment started. So that's the story about the Vivitrol injections.
Yeah, we had that in our jails here as well, and it was a tremendous idea. The problem was there was no follow up, there was no suggestion of treatment or post release, and I think Vivitrol kind of went the way of incarcerated because the counties and the states could find money for something like that because inside it would work because they could mandate it, but they wouldn't in California. They wouldn't mandate it post release. They couldn't make people go get a Vivitrol shot even if it was donated. They have to leave it to the individual to say, "I will come and voluntarily show up." It really is interesting. Yeah, we have 2 new laws in California in January, and both of them have restrictions for what law enforcement can do with them, and they can't mandate. They can pick them up and put them in treatment, but they can't make them stay. Even AMA. So it's really hard. And with our homeless problem we have here in California, Prop 36 and Prop 30 and Prop 1 are set up for law enforcement to have a much bigger hammer now. And the public defender is now working with the DA, or the DA with the public defender, to try to get the hardest to serve. I call them the frequent flyers, the ones that are in ER every week. That's their healthcare plan, and try to get them to, the next level of support, whatever that's defined as, whether it's MAT or buprenorphine or some other modality, along with, follow-up outpatient treatment, so they can learn how to live life without anesthetizing themselves.
So a couple of years ago, I came across an article called Portuguese Health Response. So addiction is a global problem. No society is immune from it. 15 years ago, they said enough is enough. We have 10.5 million people living in our country, and X number of patients have problems, and they can't control it. So they created a central agency. They started treating addiction as like any other chronic disease. And they felt treatment alone was not enough. These people were demotivated, didn't want to do anything. So they created educational seminars to reverse their demotivation. Then they rehabilitated, provided education, job training, job placement, and now they have 90% budget in treatment and social programs and 10% in law enforcement. And we have it the other way around. And whatever we do in treatment and social programs, we cannot show efficacy, effect, positive things. So I asked this question to some people. I said, why can't we do this in our country? They said, well, Americans have choice. And if they want clean needles and heroin, they want clean needles and heroin. They want Narcan, they want Narcan. They want fentanyl, they'll get fentanyl. So that is the problem, is the American choice people have. And a lot of times people don't make right choices, informed choices.
Well, I hear, we hear that with the homeless here. We can't make them leave the street. it's their right to do whatever they want to do. And if we're offering them treatment, but they don't want it, we can't make them. It's horrible here. I mean, it's like now everyone's driving around complaining about all the problems and they want to get rid of it. And, now with the tourist issue with Canada and California, they're not coming across the border because of what's going on. Now the economic piece is triggering in a bad way. So we'll see I think this is going to create an opportunity for some change because everyone's screaming right now. And, the government can't fix this, in my opinion. They just can't. I mean, they could help pay for it, kind of like with COVID. Yeah. They found a way, real-time data, real-time solutions, real-time equipment, real-time vaccines. But look what it took. And, we're going to see a swing around. COVID showed us that people don't manage their feelings well. And if they have underlying untreated trauma, most people are going to find a way to fix it. Mm-hmm. And, all the fast food restaurants, a lot of them are closing now. So food's not going to be a go-to. And, there's so much gaming you can do because if you don't have money, you can't gamble. Mm-hmm. But you've got to eat. You don't have to gamble and you don't have to do drugs. Plus the stigma, Aaron, as you know, is still around. So it's not like people stand up and go, what can we do in order of priority to really not only save lives, but prevent people from, by giving them education tools, a continuum of care, and options and opportunities. So pick one.
So the stigma issue is very complicated because stigma is at several different levels. Stigma is towards the disease, towards the treatment, and towards the success of the treatment. And, the organizations, AAs and NAs, they do not want people to be on Suboxone or Vivitrol because they think you're substituting one addiction with another, even though it has been proven again and again, Suboxone is not an addictive drug. It is a maintenance drug. I have very successfully, over the last 5-6 years, reduced patients' dosages 30 to 50%.
So why doesn't the AMA hire you? Because I know they've talked about adding a day in medical school that learn about addiction. Why aren't they hiring an expert like you who've been doing this for decades to not only create the curriculum for the schools, and you may already have it, and also to be the thought leader to speak to the AMA on a regular basis and share that knowledge? I mean, it's like you said earlier, the grants were around from the settlements, and I didn't get that money.
So I'm a small town rural doctor who is not visible. The doctors that are visible are at a national level, belong to the hierarchy at the American Society of Addiction Medicine. If they're not promoting what I'm promoting, then the AMA and the government is only going to listen to what that organization says. Even though I have met the new president-elect of AMA, I've reached out to the Secretary General and so many other politicians. But the media and the policymakers do not know how to fix this. And so they do not know what to do with it. Now, the new president-elect, who's going to be in effect next month, I just met him last week. We had a Michigan State Medical Society meeting, and he was there. And he said, okay, send me the slides. But I said, do you have time to look at it? He says, no. So I wonder what's sending it to him. Maybe he'll give it to a staffer or not, but I've not taken him up on his offer to send my slides to him.
So, Aaron, with winding down here, before we close, I like to ask people all the time. I know you're a serious man, you got a serious job, and you got serious goals. But what do you do? What does Aaron do for fun? What is your fun time?
Well, in the summer, which is May, June, July, August, and September, which I'm going to start as my garden outside. I spend most of the evening outside the house, so I don't have to sit and watch TV. I do swim. I used to play tennis, and I do a lot of educational seminars, like I'm going to the Calgary Rotary meeting. So, I walk. I started going to the gym a couple months ago, and so that was fun for me. I did not enjoy playing golf so far. The guys who I know, they're serious golfers, and they don't like people like me who go there to have fun and chat, and they don't like to chat. And so I said, okay, it's not for me.
Well, that's good. So, Scott, what do you got in closing?
I learned a lot today. Thank you, Aaron. You put some things in perspective that are different. It sounds like, if you really want to fix your problem, you should start a podcast. then you can bring all those intellectual people to your show and introduce yourself that way. So, because it's a tough one. I know the same thing. I mean, I'm a subject matter expert. I don't get picked up. I missed Overdose Day, Alcohol Awareness Month. My normal media people, because of the news cycles right now being so, absorbed with immigration and what's happening with the White House and what the leadership's doing, their day is full of that kind of news. So, it'll come back around again. But, I don't like the dips and valleys, and I've been at my own personal recovery for 40 years. I haven't practiced medicine like you have, but I certainly have been trying to help others. And, it's a tough customer, first of all, denial, inability to feel emotions. And then, of course, the toxicity levels of everything that's out there today has really increased, to your point. So anyway, but it was great having you here. And, let's, I know you won't give up, and I'm not giving up. And I won't golf, but what I will do is I'll drive the cart and I'll smoke a cigar. I'll take you around. We'll get a 6-seater and we'll get a couple of mucky mucks in the back that have to listen to us if we drive into the water.
So, yeah, I had offered you before. I mean, if you have other guests and you want me to join them and have a discussion, let me know. I'm open.
Okay, thank you.
How can people get a hold of you?
Well, so my office phone number is 734-241-7162. I have a website which you can reach me through the Preventable Epidemic book. I have a SOS Foundation. You can reach by my name. My address is 1094 North Monroe Street, Monroe, Michigan, 48162. And I'm easily searchable on Google also.
Yeah, and I'll gather all that information. I'll put it in the show notes below. Okay, Scott, you want to drop your phone number real quick?
619-993-2738. And if I don't get a phone call by the end of May, I'm going to change my phone number to make it harder. 619-993-2738. Call me if you need to get a hold of the doctor, if you didn't catch what he said, but you can play it back again and share it with your friends. Let's work together to help save lives. And if you know somebody who you think might add value to the show we're doing, have them get in touch with Fred or myself. And let's keep moving forward, because the government's not going to fix this.
Nope, they aren't. Okay, so that's going to be it, Scott. That is it for Your Crisis Coach with Scott H. Silverman and me, Fred Carroll. We want to thank Arun Gupta for joining us. Dr. Arun Gupta, you earned it. Dr. Arun Gupta. And we will see you again. And if no one has told you they love you, we love you. And we'll see you again next week. Goodbye, everyone.
Thank you very much. Yeah.